Welcome students to the session on saliva and its role in dentistry. This brief presentation will be more focused the role of the saliva and its clinical implications. The primary issues we will address. Now, the major salivary glands, that is your parotid, your submandibular and sublingual. These three are called as the major salivary glands. There are many minor salivary glands. One is the labial and the buccal, glossopalatine and palatine, lingual salivary gland, glands subgland unknown, wound epidermis glands, and the posterior salivary glands. So this is how the salivary gland is classified. The main chunk of your secretion, that is almost 60-70% of the salivary secretion, is through the major salivary glands, and more primarily of the parotid gland, then the submandibular, sublingual. Okay, and now the chemical constitution of the composition of the saliva, the enzymes, the proteins, the nanoproteins, and the water-soluble vitamins. These four things are present in the saliva. And when it comes to the enzyme part, the most important thing is the salivary amylase. Salivary amylase is the important enzyme that is seen in the saliva. Then is the maltase, lingual enzyme, lipase, lysozymes, phosphatase, carbonic enzymes, anhydrase, sialoperoxidase, and esterase. These are the enzymes. Okay, and don't get confused with all the primary thing you should remember is the salivary amylase. Then the proteins, the mucins, the glycoproteins, the lipoproteins, the albumin, IgA, IgG, and IgM, free amino acids, intrinsic factor. These are the protein part that is the saliva. The non-protein nitrogenous substances are urea, uric acid, creatinine, hypoxanthine, xylene. The non-protein nitrogenous substances, it's commonly the urea, the uric acid, the creatinine, the xanthine, hypoxanthine, xylene. The vitamins that is seen is vitamin B and vitamin C. This forms the composition of your saliva. It should be categorized like this: the enzymes that is present, the proteins that is present, and non-protein nitrogen substances that is present, and the water-soluble vitamins that is present. Clear? And as I told you, the topic of discussion: saliva and its role in dentistry. What role does it have in dental caries? Previous session, we were discussing about the dental caries lesion, etiology, pathogenesis, prevention, and some treatment part of treating patient with dental caries. Now, what's the role of the saliva and dental caries? Okay, saliva and the role of it, rate of the flow of saliva, the pH of the saliva, buffering of the saliva, calcium and phosphorus concentration of the saliva, the ammonia concentration of the saliva, the opsonin, the glycolytes activity of the saliva, the antibacterial activity against lactobacilli and streptococci mutants. These two bacteria are more commonest. These two Most commonest bacteria that creates dental caries. The Streptococcus mutans, your lactobacilli. How does the rate of flow of caries, if suppose there is decreased salivation, rate of flow of saliva is decreased, then eventually the self-cleansing mechanism, the natural mechanism of cleaning your teeth, that gets affected. If that gets affected, then food debris or bacteria, whatever it stays in the stuck to the tooth structure, and the time, the duration of food particles, food debris, the bacteria that stays in the tooth structure creates the caries lesion. So the rate and flow of saliva is important. It is directly proportional to the caries lesion. If suppose the pH is more, salivary pH is more, then eventually it will progress the caries lesion more fast. Dissolve the enamel very easily. The lesion will be carried out to the next layer, the dentin, very easily, and it will affect the pulp very quickly. So the sequelae of the pathological condition, it progresses, increases, the pH, the saliva is increased. So saliva has a direct role in a caries lesion condition patient. If suppose the calcium and the phosphorus concentration is more in the saliva, what does it mean? What does it imply? It clearly shows that your enamel is getting dissolved. Your tooth structure is burned out more readily. Then only you'll have the calcium and the phosphorus concentration will be more. That means there is more rampant caries is there. Then if it is more, ammonia concentration is more in the saliva, even that will promote the progression of the dental caries. So the oral diseases, okay. See for suppose a simple tooth decay, dental caries, or a periodontal disease. Periodontal disease is disease that is associated with the gums, the adjoining structures seen around the tooth. That is the gums. The problem with the gums, that is periodontal disease. The salivary gland disorders, in carcinomas, any tumor, leukoplegia, or any fungal infections, candidiasis, and the inflammation of your oral cavity, stomatitis. In all these clinical conditions, your saliva gives a very good clue. See, the clinical condition, there can be hyposalivation, or there can be total dryness of the mouth. That is called as xerostomia. These two things, as a clinician, you should be well versed. What if, and what are the effects of xerostomia? Dry mouth, no retention for the dentures, and easily abraded mucosa. Then there will be friction in mucosa. Patient can't bear tension. Cancerous lesion pertaining to the salivary glands. The most common form of benign salivary gland is your pleomorphic adenoma. The most see in the picture, this pleomorphic adenoma involving the submandibular salivary gland, the most common benign salivary gland tumor, composed basically of a proliferation of myoepithelial cells, wide spectrum of epithelial and mesenchymal tissues, and surrounded by a distinct fibrous capsule. This as the capsule is encapsulated, the tumor is encapsulated. Some areas present cuboidal cells having a ductal-like pattern with an eosinophilic coagulum. In other areas, tumor cells may assume a stellate, polyhedral, spindle shape. Some even show chondroid or osseous characters. Treatment. The treatment part for pleomorphic adenoma, the surgical excision, lesion in the superficial lower parotid gland, then the superficial parotoidectomy with preservation of facial nerve. Tumors of deep flow, then eventually the total parotid has to be removed. That is called as total parotoidectomy. Submandibular gland tumors, total removal of the gland is the ideal. Tumors of palate, excision to the periosteum. And the good nature of all these tumors, salivary glands, only 5% of it will train it to be changing to a malignant lesion. 5% risk is there for malignant transformation. That is the tumors that arises in the salivary glands. The other most common problem that's seen is mucocele. Mucocele is nothing but if there is disruption, the path of saliva, saliva gets accumulated, saliva gets accumulated, and it turns to be a swelling. That is called as mucocele. Saliva tension will be there. Most commonly affected area is your lower lip. The patient traumatic bite, minor salivary glands will get affected. There will be a disruption in the salivary flow. So the tension of the saliva will be there. There won't be any normal salivary flow. Now obviously, patient will end up with a swelling. That is your mucocele. And the treatment part is total excision of the salivary gland, the minor accessory salivary glands, most commonly seen in the lower lip, and is more recurrent also. If suppose the patient is having abnormal tooth position is there, where every nerve on and off is biting, the tissue gets stuck. It bites the minor salivary glands, ended up with mucocele. So lapse is more common in that condition. That part, eventually, the tooth position has to be corrected. Abnormal tooth position. Abnormal position of the maxilla and the mandible. Abnormal individual tooth position. Abnormal positioning of the maxilla and mandible. See for suppose any bite difference is there. Patients having a cross bite or a deep bite, then chances there for the patient to hurt the minor salivary glands, more commonly seen in the lower lips. So it turned out to be a mucocele. Then the next part is as I mentioned earlier, the saliva and the relationship with dental caries. Okay, dental caries is a bacterial lesion. Okay, more prone in the pit and fissure area. The last session regarding dental caries, we explained to you about the pit and fissure caries. If suppose there is reduced salivary secretion, hyposalivation is there, or patients having xerostomia, then eventually you can look for a multiple caries tooth. Multiple caries tooth will be clearly, that is one clear clinical sign when you come across a patient who's having a problem in the salivary secretion. More multiple tooth decay is more common. The other thing is saliva has an antibacterial property. One more thing is really has an antibacterial property against Streptococcus mutans and Lactobacillus. These two bacteria are the main reason for the caries lesion. Two bacteria main reason for this caries lesion. So eventually, saliva has a pivotal role in preventing caries lesion. Individually, when you speak about the characteristics of saliva, one is the amount of secretion, the rate of flow, pH of the saliva, the buffering nature of the saliva, calcium and phosphorus concentration of the saliva, and the antibacterial property against the bacteria are of prime importance. But this plays a prime importance in preserving the tooth structure. Preserving the tooth structure. And before winding up this session, I want to brush up again the important aspects as a general practitioner, clinician, what's supposed to know about the importance of saliva and its role in dentistry. For the prevention of dental caries, prevention of periodontal disease depends upon the normal flow of saliva. The effects of the xerostomia, dry mouth. Elderly patients with dentures, find it very difficult to wear the denture if there is an hyposalivation. They can't. The intolerance to wear the denture. There will be a frictional irritation to the mucosa, and your mucosa will get easily abraded, ending up with recurrent ulcerative lesions. It's more painful and more concern for the elderly patients. So the effect of saliva, okay, in preventing the caries lesion, the periodontal disease, and the well-being of your oral mucosa. Your mucosa changes. There is a decreased salivary flow, hyposalivation, eventually mucosal abrasion will be more, ending up with recurrent mouth ulcers, making the patient more intolerant. The other aspect, most commonest thing is the tumors that is associated with salivary glands. The pleomorphic adenoma, the most common benign salivary gland tumors, most commonly involving the submandibular salivary glands. More, it is covered with a distinct fibrous capsule. That means it is encapsulated. The good part of this, 5% risk is there, changing into a malignant lesion. before winding up this session, to really make you understand the condition prevailing with the hyposalivation and xerostomia, and the importance of the salivary secretion, and make sure that this helps you. I think I would have enlightened more about you about this importance of saliva. Thank you.